Yeah, hello. I see many people coming in, so we're going to wait a minute or two before we start. Okay, I think we can get started. Good afternoon, everybody. My name is Damiano Rondelli. I'm the Center of Global Health in the College of Medicine. And I'm also the Chief of the Division of Immunology and Oncology here at UIC. It's a great pleasure today to have as a speaker for our colloquium, especially in occasion of the World Day for Cancer, to have Dr. Nelson Chao, who is a special academic and clinician and a human being. Dr. Chao did his undergrad at Harvard Medical School at Yale, and then he went to residency at Stanford. He also did a fellowship in oncology. He also got an MBA at Duke University. And after starting working at Stanford, he moved to Duke, where he's been the director of the bone marrow transplant program since 1996. He has many titles and awards. He's also the Donald D. and Elizabeth G. Cook Distinguished Professor. Has been the chief of the Division of Hematology and Malignancies at Duke. And has been the director of the Global Cancer Program at Duke University, and is the founder of the International Cancer Care and Research Excellence Foundation. He's also now a research professor in global health. He has served in many committees, national, international. He's in the board of directors of International Cancer Expert Corps. He's a board of scientific advisor for the National Cancer Institute. And he's also the co-chair of the Global Health Strategic Initiative, which is an administration for strategic preparedness and response. His interest in interest has been always in bone marrow transplant. He's a very well-known immunologist in the space of stem cell transplantation. But he's also interested in global studies, especially in mitigation of radiation effects and global oncology. He has an outstanding curriculum with 387 peer-reviewed publications, many books and many book chapters. He has been an outstanding researcher in the space of bone marrow transplant, but his commitment to global health, and I think the work he's going to present today will show it, is actually the core of his mission. So I welcome Dr. Chao, and we look forward to your presentation. Thank you, Nelson.
Damiano, thank you for that kind introduction. As I was talking to Damiano earlier, I don't know of anything global these days as being welcome, but I will hopefully strive to show how much good we can do. So I want to start just with what the Global Can report was. This is 2008 data, but it showed that for the first time, non-communicable diseases were taking over as a major cause of disease and mortality. You can see global cancer is a significant problem, and especially in kids, where I think the disparity is just so much more pronounced in terms of survival. So in high-income countries, about 80% of children survive, and compared to low to middle-income country, only 20% of the children with cancer will survive. And there are social justice and health inequities we have to address. It's a complicated disease. Cancer is not a single disease. It requires multidisciplinary approach. It's very expensive. The incidence varies, and the type of cancer varies. It's socially problematic. It's unknown or unspoken in many areas. And probably one of the major issues for cancer or oncologists or hematologists in low to middle income countries is that there's no career path in this country, right? So if you are a malaria researcher, HIV researcher, infectious disease, there is a career path as a scholar, as an academic, where that doesn't really happen in cancer. And lastly, one of the issues really is that oncologist salary is reasonable for an academic, and to make up that salary with R01 grants is really quite a challenge. So where do we start? I started this now probably about 11 years ago now, and I'll start with a case. This is a case that was a patient that was in Mwanza in Tanzania. It's an 8-year-old child, has joint pain, fever, splenomegaly. Hemoglobin was 1.2. There were no platelets, and obviously had a high white count. And this is it, right? You have right stain, you can look, and that's your diagnostic studies. Same time, this is a 53-year-old gentleman with fatigue. CBC showed a white count of 135,000, hemoglobin 7.5, platelet count 31. Is this AML? Hard to say. White count of 135,000 for AML would be pretty unlikely with him still being alive. But again, this is it. You don't have much more to go by. So when we start doing this, it's pretty clear that you need a lot of intertwining circles. You need dollars clearly to not only to treat patients, but to have the ability to do research. You need to understand what the incidence is. You want to know what the survivorship. You need to educate. You want to prevent. You want to treat. You want to be able to diagnose, and you have to have palliative and supportive care. And it's not. You have to start all pretty much at the same time to try to get there, because if you just start with prevention, which is where most of the global cancer has been, and cervical cancer prevention, there really is a lot of bits of this that is missing. And there are a lot of difficulties. We don't have imaging, and we don't have pathologists. So if you look at the number of people served by pathologists in sub-Saharan Africa, most of this is in the millions. So millions of people with a pathologist. So it is quite different from the US or the UK, where it's one pathologist per 15 to 19,000 people. Surgery is another big issue. There's plenty of surgeons in many parts of the world, but in sub-Saharan Africa, it's less than 2 per 100,000. So again, a major problem with access. And radiation therapy is even a bigger problem, because there is the lack of the machine, and when there are machines, there's a lack of service. So you can see in the goal for the radiation therapy folks is to have 1 per 20,000 people that would service the majority of them. In Tanzania, there are 5 for 50 million people. So it's and it's there's 2 in parentheses there because there are 5, but there are usually only 2 that are actually working. There are lots of other barriers you can imagine, right? Hygiene, infection, nutrition. This is one of the pediatric wards in Mwanza where we are. And you can see that nutrition is a big problem. A lot of these kids are malnourished in the moderately or the severe sense. And lastly, I think if you look at a comprehensive cancer center or comprehensive cancer treatment where we all sit, we have lots of pieces that fit to take care of the patient, right? Starting from the oncologist to radiation oncologists, oncological surgeons, dedicated pathologists, radiologists, pharmacy, nursing, rehab, palliative care, supportive care. I mean, these all are pieces which give a holistic approach to the patient. And you can imagine that in a country where there's very limited resources, you probably have 1 or 2 of these pieces, but not much more. So I started this in 2013 as it was an effort by the Duke Cancer Institute and the Duke Global Health Institute to bring global cancer to the Global Health Institute. So a pot of money was set aside, and I went and looked at different places. I decided to try areas around sub-Saharan Africa because there was a Duke presence already in Tanzania. And in 2014, we established this Duke Bugando Medical Center partnership. Bugando Medical Center, I'll show you in a minute where it's at. For a couple of years, we did a need assessment. We established what the baseline outcomes were at that time, and we started the goal of building clinical care first, and then build the research infrastructure. Did not want to start with research because I didn't want to just take data out, but really wanted to have the ability to deliver care. So we did a 3-pronged approach. We started a cancer treatment center in Bugando. We then had a education center with Tata Medical Center for training. And the concept there was that the people in Tanzania would go to Tata to train. And we sent a radiation oncologist, a gynecological oncologist, and a medical oncologist to actually train in Tata for 1 to 2 years. And the reason for that is they speak English, they do practice, sometimes in a resource-limited environment, but they also have plenty of resources if the patients can pay. And in India, the Tanzanians actually can touch the patient and can actually work as registrars, delivering care. Whereas if they came to the US, they could only observe, and probably most of the stuff they learned would not be particularly helpful in Tanzania. And then we have a large research agreement with Barretos Cancer Center in Brazil, and we have multiple sites in China. And the idea was to really plan diagonal healthcare, where we would actually do the South-South exchange to try to have these partnerships that would be beneficial. So after a couple of years of looking around, I decided to focus on pediatric patients. These are more curable. It takes less chemotherapy. There are lower numbers of cases. Potentially, we could actually lead to more awareness and potentially more fundings. So I call it 3 Ts. There's toddlers with tumors in Tanzania. Part of the reason for pediatric cancers was that spending some time in Tanzania on the adult side, most of the adult cases, I would say probably 90–95% adult cases, were patients with stage 4 disease. And there's not much chemotherapy, so many of those patients really would have benefited much more from palliative care rather than from chemotherapy. So they were using single agent adriamycin for stage 4 breast cancer patients, which really, provided very limited palliation. So these were the data at the time. There are, as I said earlier, 250,000 children diagnosed with cancer. That's about 700 children per day, 1 every 3 minutes, and more than 85% of cancer cases and 95% of deaths are going to occur in these poor countries. And until recently, this has really not received much attention from either research or health organizations. And that the imperative of this is that the majority of these kids can be cured with prompt and effective and complete therapy. So you can see that, in the 5-year survival in the developed world, you can see that there's a continued improvement in 5-year survival. And in these low to middle income countries, the cure rates are really quite low. So this is just a picture of Tanzania. Tanzania has about close to 50 million people. Dar es Salaam has the Ocean Road Cancer Institute and Muhimbili University, where it's probably where the center where most of the cancer is being treated. So 2013, when I started, there was a single oncologist for the country. So there were radiation oncologists that were delivering chemotherapy, but there was a single Western trained medical oncologist who was trained in Italy, did his internal medicine in Tanzania, went for 3.5 years to do medical oncology training in Italy, and then came back. So there are 3 centers. There's Uganda Medical Center, which sits in Mwanza. There's the Kilimanjaro Christian Medical Center in Arusha, or Moshi, and the Ocean Road in Dar es Salaam. These are the only 3 places that treat kids in a pretty vast-sized country. So to put in context, if you overlay where Tanzania is, you can see the amount of space that would occupy over the map of the US. The place where we settled on was Buganda Medical Center. It's a 900-bed hospital, serves a population of over 13 million. And about 5 years ago now, they built actually a separate building for oncology, which is actually quite nice for the patients. So before we started, we looked at the demographics we had in between 2010 and 2014. There was a total of almost 300 cases. Based on estimates on the population that exists there, we were expecting about 1,089 cases. And only about 5% of pediatric cancer have been present for treatment at Uganda. So really a major deficit there. These are most of the diseases that we're seeing at the time. Burkitt's lymphoma, and if you add non-Hodgkin's lymphoma to that, are the majority of those cases, but there are womb tumors, leukemia, retinoblastoma, and neuroblastomas make up the other vast types of tumors. And this was a survival of that group. It was quite dismal for that period of time. So, we figure, well, we've got to educate that there's a cost issue because chemotherapy is not available. So the patients, the families have to buy the chemotherapy to bring for administration. And there's really limited treatment capacity. So we took, for this data, we took 185 files. We collected the data on demographics, diagnosis, treatment, and outcomes. And you can imagine this is what the charts look like. This is not an electronic medical record. It is lots and lots of paper, some of which is useful, some of which is missing, some of which is misfiled. So it took quite some time to try to get useful data. And the good side of this is the cost is really pretty low because these are not, these are original chemo. So it's the WHO has a list of 15 essential chemotherapy drugs. The country has on average 8 of those at any particular time, although this is getting better. And it's quite a barrier because patients have to go across the road to the pharmacy to buy the chemo and bring back. And so they have to purchase it themselves. But the overall cost of care is really pretty inexpensive to treat these kids. Now, the average salary for most people there is $1 a day. So it is, in relative terms, clearly expensive for them. So if you can't measure anything, you can't fix anything. So we started a hospital-based cancer registry, and we started with standardized pediatric protocols. And we also started our NGO to provide free chemotherapy. So Duke had provided the infrastructure money for our offices and to start a research base, but obviously we couldn't use Duke money to go buy chemo for kids. So we started this NGO so that we could actually supply this. And so when we looked at it, this was the drugs, it was 90% survival rate. And what was very telling from this data is that the level of abandonment of care was extremely high. So almost 80% just didn't finish the therapy. And the reason for that was some of it was not unreasonable because the disease grew. Sometimes the medicines weren't available or they couldn't buy the medicine, but 61% of the patients just abandoned care. So just they got treated with 1 or 2 rounds of chemotherapy and they just never came back. So these are the priority lines. These are the drugs that were sort of consistently available: cyclophosphamide, 5-FU, methotrexate, and Kristen. The rest of the drugs, like donomycin, were not always available for use. So it makes regimens and the ability to treat people without this foundation really not possible. And as you can imagine, you know, we have hoods and we have all these ability to do or to deliver or to mix and deliver chemotherapy in a much better structured environment, whereas here we're you know, they're just mixing chemotherapy out in the open. And they don't necessarily have very experienced nurses. So, you know, extravasation was a real big problem at the time, as you can see here. And this is a laboratory. There's not a whole lot. There is a CBC analyzer. You know, the ABO blood type matching is done on these pieces of paper. Sed rate is done, like as you would imagine, putting the blood and waiting for it to sediment in these really ancient looking things. And this is the extent of the heme lab. So we looked at this and we said, we came in, we said, oh, you know, we know everything. We're really good at doing what we do. We're going to make this much, much better. And so, as I showed you earlier, pre-2015, there was the survival, patient survival was 18%. A year later, we looked at our data, it was 19%. And the number of patients before, you know, in 2014 and 2015 really didn't go up in the same number of patients. And so obviously, we were trying to do something, but obviously it wasn't working. So these are the major balls up in the funnel to try to figure out what can we do to make this better. And that year, the abandonment care was still about 50%. So we would start with what would look like reasonable therapy, but then patients wouldn't stay. And so we looked at the factors why folks left. And basically, one of the big problems was it took a long time to diagnose these patients. So these patients got admitted because they had a mass. They would sit in the pediatric ward for a month or more before an oncology consult would be called. And that's sort of historically, they would just, you know, oncology when we started was a disease that nobody wanted to talk about. It was a clear death sentence. And so it was ignored as long as it could. So we looked at why patients didn't complete. One was there was a delay in diagnosis. The other was travel distance. The provider didn't know about cancer. There's a long referral delay from the outlying clinics, and the caregivers really didn't know much about cancer. So what could we do? So we did create a cancer registry to know what was happening there. We got a P30 grant to look at patient database for treatment, diagnosis, and outcomes. As I mentioned earlier, we standardized these pediatric protocols. We hired a patient care coordinator to teach patients about and the families about cancer. And then the coordinator would actually go and round on the pediatric wards every day to suggest who could be referred to oncology. Then we partnered with this NGO we created to assist in the cost of care. And the coordinator would actually follow with the patients after they went home with a phone call to ensure that they would return for their visits. So the delays are really quite quite a bit of a problem. So patient gets admitted with a mass, the registrar orders a diagnostic test, and they have to wait a few days because the family has to pay for the test. If the test shows that there's a suspicion of malignancy, then you have to biopsy. Once you get biopsy, you have to find a pathologist to read it, which might take 30 or 40 days. And so once you get a biopsy, then you get referred to oncology. So this took 49 days on average. The care is complex and treatment process are complex. There are communication information barriers all along the way. And so now the way that that's been helpful was that we, because this coordinator walks around the ward, the day the patient's admitted, there's a mass. The onc team gets notified. The onc team will go see that patient or the diagnostic test. The testing fees get paid by iCare so that it can get done. The biopsy can get done really quickly, and then the biopsy results get read faster because the oncology team actually takes it to the pathologist to look at it. So that has helped quite a bit. This patient navigator has been a significant improvement in this, at least in this barrier. So this has made a major impact. The evaluation time has dropped significantly, and the time to diagnosis has actually dropped significantly as well. And because the patient navigator calls the patient after the patient goes home, there has been less abandonment care, although obviously 29% is still too high. And the overall survival has picked up. In 2016, it's gone up to 39%. So this was encouraging that some of these things were making an impact. The other part, of course, is, as I mentioned earlier, the distance traveled is huge. So some of these patients and families are taking more than 10 hours to get to Uganda. Remember, Uganda serves a population of about 15 million people in a huge area. So it's and the roads are not the best. So sometimes it takes a long patients to come. And the travel distance is about 4 minutes. So you imagine the bus takes longer, and if the patient has to come back and forth frequently, it also costs money. So in 2017, we started a hostel program, and actually this work was done by Christian Schroeder, who is the faculty member I hired to live there. And she came to work one day in early 2017, and there was a 10-year-old boy who was getting chemo, who got chemo the day before and was getting chemo again that day, was sleeping on the ground outside the hospital because he had no place to go. And it became, it's obvious when you think about it, but if you don't think about it, you don't think about it, you don't know. We don't think about housing our patients here, but obviously there was no place to house the patients. And so we started a hospital. It's now 4 houses. It can house about 40 kids with their one family member. And that has allowed them to live there while they're getting their chemo, which has also helped quite a bit. And that also allows social worker to come and help support the family and educate families about cancer. And the hospital really has made, I think, a difference as well. The hospital does allow kids to live there. Their quality of life is better. And there, not only do we provide housing, but we also provide food with high nutritional value. And the community knowledge has increased. There's a lot of faith healers out in the rural areas of Tanzania who have very mythological understanding of cancer, which needs to be addressed. And we have open houses. We bring community members with or without cancer to try to understand what cancer is. So there's large groups, people talk about it and bring education to the people in the rural areas. There are radio announcement posters, village meetings, all trying to increase community awareness. And that has led to a surge of patients. So it's actually more than double. Than this past year, we had about 320 patients. So that has really increased the total number of patients. That also has, unfortunately, increased the stress on taking care of these patients. So there is a referral hierarchy. The community level is primarily traditional healers. At the village level, there's these health dispensaries, and there's district hospital, referral hospital, and consultant hospital. So it does take a long time for the patients to make it out of a traditional healer to get to one of these national referral centers. So there's a lot of effort being placed on staff awareness. So patients in these more rural areas understand why cancer is important and why early referral is important, and that the cancer is not necessarily a death sentence for these kids. And the training does work. Post-training, you can see there really is usually a delta of improvement and understanding of what cancer is, what to do about it. And what's been really great is there's been a constant stream of volunteers to come help and develop the research capacity and help with the treatment efforts. We did make an app with one of the Fogarty scholars to try to include navigation of the chemotherapy. So how to dose, how to give chemotherapy, how to adjust chemotherapy. And I think that's been helpful as well. So what we had proposed in one of our P30 grants was to have this patient navigator do the intake, provide a general education, then tailor that based on the diagnosis of that patient, what that patient would expect. The patient would, the caregivers get randomized to receive one of the 4 education strategies. It was just a piece of paper, or it was text messages, and it was interactive, iPad, and then all 3. And so I think outcomes have improved. So 2-year overall outcomes have gone up to about 50%. The number of patients have increased, and treatment abandonment has decreased. I will say that the last year we looked at, the outcomes have dipped down to about the high 30s. I think this is probably a reflection of the total number of patients coming in, which have been sicker than the initial group. But it does give one a lot of joy seeing kids getting well. So we still have community educators. We still create education material. We're training parents in the local community. We're now giving nutritional supplementation. So we've developed a very high protein supplement for each of these kids based on peanut butter. And we're working on a national children's cancer network so that these 3 referral hospitals actually can partner to have common SOPs. And basically, many of these folks could probably get to a major cancer center in about 4 hours. So this is basically a hub and spoke proposal to try to get these consultant hospitals at the center of the hub with spokes radiating out. I'm just going to finish with the other two parts of global cancer we did. One was with Tata Medical Center in Calcutta is, it looks like a Genentech building in San Francisco. It's beautiful, well done. We trained one of the registrar there. In exchange, they brought their nurses to Duke to see how we were doing. That partnership has really been fantastic. The other is with Bugando, with Barretos Medical Center in Brazil, in Sao Paulo. That is another remarkable place. It looks like MD Anderson. It is completely free for the population of Brazil, and it is providing really a state-of-the-art care for these patients. We've had fellows live there for a year, present data, do research projects there, and that's been really quite educational. It really is a special place. Cancer Care is free. It's a leading tertiary cancer center in South America. They see about 10,000 new cases. They have the largest screening program established in 1967. And I think it's the only place that I know of in the world where the faculty are paid by rank. So their neurosurgeon, full professor, and their pediatrician, full professor have the same salary. And they have this huge mobile unit screening program where they have these 18-wheelers which drive all around the country, rural areas, providing free screening. So there we were building research capacity and looking at partnerships to respond to international research proposals. They have a huge biobank. You can see down below the picture of one of those 14 wheels, these 18-wheelers being floated down the Amazon River. I'm going to end with a personal note, which was really, I think, fascinating. I was in Serengema in Tanzania, which is a very rural area. You have to take a ferry for about 45 minutes and then another car ride for about an hour to get there. And it's one of these spokes where we had a pediatric cancer program. And this place was run by a Belgian nun that was about 5 foot tall. And she did everything. And she was an internist, but operated on anything and everything. And she had this individual that had dermatofibrosarcoma protuberans about 10 years before. And it's a disease that if you do a very wide excision, it's not a malignant disease. You do a very wide excision and it's gone. But if you don't do a wide excision, it keeps coming back. And for 10 years, she'd been plucking these things off this individual's abdomen to the point that he no longer had fascia left where she could reattach. So he had these lesions that were clearly visible. And I'm really literally out in the middle of the bush. I've never seen dermatofibrosarcoma protuberans. But I did have one neuron in the back of my head fire because I've seen this written somewhere, and it turns out that it's a PDGFR mutation. And so reading about CML and reading about TKIs work for this disease. And so I said, well, let's put them in imatinib. Well, we're in the middle of the bush in Tanzania. This is about 8 years ago now. And there's no imatinib in the capital. There's going to be even less likely to be imatinib out in the bush. So I get back, I email my contact at Tata, and I said, hey, can you send 6 months worth of imatinib to me? He said, I'll buy it in India. He said, nope, we'll send it to you, it's free. And so he sent it to me. We gave it to this individual. This is his belly, which was full of these tumors, and it's completely gone. As you can see, he really doesn't have much fascia left, so he really couldn't have surgery. And this is 2 months afterwards, he's just gotten married. So I like to think Duke was well positioned to partner with developing stakeholders. These analytical models could be applied um, to any country, and this cross-disciplinary training actually helps um, the folks in those countries, but actually helps physicians at Duke as well to specifically understand, how we can actually treat patients here too. So it's really it's not just a one way; it's a two-way. We learned, for example, from the folks in India about using single agent melphalan in an auto transplant without having to freeze stem cells. It's a long list of people to thank. I especially really do want to thank Kristen Schroeder, who actually lives in Tanzania for 6 months and actually has done the vast majority of this work. So I'll stop there. I'm happy to take questions.
Thank you, Nelson. It was an amazing presentation. I think I share everybody's comments. I think it's extremely interesting, and the three things actually caught my attention, and actually I keep seeing in your presentation was the relevance of the type of partnership that you developed. I was very impressed with the fact that you want to first start the clinical service before talking about research, because it's not really colonizing the place, but just supporting their need. Also, the fact that it's an impact-driven work. It's not just to get something out of it, but just step by step for the first, can say failure or difficulty that have been addressed. And I think there are many things to learn from this work. The institutional mission that you presented, that was indispensable. So before other people may ask questions actually through the chat, please, what are you think are the challenges that you still have in addition, besides the money that may be, is of course always difficult, but from your standpoint, like for people going and then the interaction with the local people, and what do you think are going to be the next challenges to face?
Yeah, so I think, we have a rudimentary process in place. I think we need more pathologists. We need better diagnostics. I just got a flow machine. So flow cytometry and flow analysis would be helpful. I think educating the population is a continued need, and something that really does take a long time to overcome these biases. And the goal really is to train the trainers. So by sending these folks to India and actually having true medical oncologists has been a big help. We did send one person to South Africa as a pediatric hematologist oncologist, and that's been very helpful. Who's in Tanzania. So I think the goal really was to try to get a group of 4, 5, 6 hemonc folks that are Tanzanians that are well trained to carry this forward. One of the big challenges, I think, is partnering with the Ministry of Health to put more support into this, and either that or just more philanthropy dollars from. Tanzania is a very rich country. There's a lot of mining that goes on, and perhaps there's a way to tap into those multinationals to invest in healthcare.
So one question is, can you speak more on efforts to help in medical education? I think you just addressed it, about professional development for local oncologists and supportive staff.
Yeah, so it really is. I mean, the goal along is that if one day we leave, or we're told to leave by powers that be, that there would be something in place that it doesn't just collapse. And I think we're pretty close to that. We do have 2 pediatric hemonc folks who actually are there carrying the ball when Kristen isn't there. So that, I think, has been a big plus.
Yes, there's also the risk of a brain drain of people being trained and then not coming back to Tanzania for better opportunities, but that's probably is inevitable. I think there are a couple of questions asking, as you see here, the financial side and the possible USAID. role. Of course, there's a time of concern. How do you see the sustainability of this project going forward?
Yeah, so we fortunately have no USAID money, so it's right now most of the stuff we do is philanthropy through eye care. And I think what is remarkable is that if you look at the cost of caring for these kids, it's $170 for a course of chemo, which to them is a lot of money. But if you get philanthropy dollars, it's not that much to actually keep going for that piece that they need. So, a US dollar there goes a long, long way compared to here.
You see, one question is, what has been your experience in learning from these challenges to developing a model for other countries and programs? Do you have thoughts on how this framework can be applied consistently in similar areas?
Yeah, so, I think I don't know that what we did in Buganda is all that unique. I think what it really requires, are just a handful of things. It requires a partner there who's committed to helping. And that probably is one of the biggest struggles probably anywhere, is somebody who's really committed to help without a lot of politics or secondary gains. Right? So I think you need somebody who is willing to partner and help. Then you need somebody who is there for the long run. Because I think one of the worst things is like to screen and have no follow-up. So tell somebody, you got cervical cancer, but there's no place for you to go to get therapy. That kind of stuff really is terrible. So you need consistency. I think having the ability to bring somebody from the outside into the program and actually live and stay there is a big deal. And thirdly, I think it's to drive interest locally, that you have local docs interested in continuing that.
Yeah. So a question from Nadeem says, in my experience as an effort to bring BMT centers in India to get FACT accredited and noticed significant challenges about acceptance of quality measures and costs associated with it. Could you comment on barriers in implementing care while maintaining quality in Tanzania?
Yeah, I think to get FACT accreditation is a huge. So the goal we had is to get a clinical trial site that would get accredited by the NIH. And the model we used there was to use the PEPFAR dollars for age-related malignancy. So to have enough checkpoints and actually to be able to run a clinical trial that would meet the NIH criteria for these trials. And we do have that now. But it does take dollars. It takes a lot of money to have the infrastructure in place. And it takes, I think, willingness of people to adopt those. It's not inherently obvious or easy for people to accept these types of workflows, and so it just takes time to educate people to do it.
Any other questions? I think that what you showed in oncology and cancer can be probably replicated in other subspecialties in almost anything. Your examples are quite clear. I think there are many things you said that are shared by people, I'm sure, that are watching your presentation have experience in many countries in different areas, and I think we share some of the comments, but of course to see the results and I think the scientific approach you took is extremely valuable, because it allows us to learn and to measure what we're doing, even when it doesn't do well. But it's very inspiring. See all the congratulation messages on the chat that are expressing everybody's feeling. Steve, the director of the Center of Health, wants to say something.
Thanks, Damiano, and thanks, Nelson. I really needed an inspiring presentation today, and you delivered 100%. Thank you for the awesome work of you and your team and your partners. I work in global mental health, and it would be very interesting to align your story of how you built things with how people are building things in global mental health. I think there's a lot of, as Damiano was suggesting, there's a lot of crossover of strategies and principles um, that would be, I think, very valuable for anyone in global mental health to hear as well. So keep telling that story. Um, but I also wanted to ask, is something that Damiano and I have talked about um, too, is with all with these successes in survival. Um, uh, Families and individuals are facing challenges, that different kinds of challenges that they wouldn't have faced, and with it can come some psychosocial and mental health burdens that now need to be addressed in a different, or there's an opportunity to address them. And I don't know if you could speak to that at all. So I guess there's issues of survivorship and at the individual level, at the family level, and at the level of practitioners or other kinds of community supports, um, help helping them to be in a position to provide a new kind of support to these kids and families who are now having good outcomes largely.
Yeah, I think you're exactly right. I think we are actually, 2 years ago, we started a survivorship program with a social worker so that these folks would come back. And it's actually been really gratifying. The hostel actually is a really um, uh, empowering place for the families and the kids, because it is really a shared community um, living environment. And it was really um, quite interesting that some of the parents who are closer will come to the hostel, even though their children have died, but will come to share a meal and cook together. And so I think that's been a very powerful community setting. But I will say, um, I think we all need a moment of clarity of why we do this. And I think the reasons don't change. So doing good is a good thing, and that won't change.
Thank you for that.
So the question about education, the population, the global strategy incorporating different understanding of wellness. That's a great question. I don't know. There is clearly different understandings of health. So I suspect wellness might be different as well in different places.
Okay. All right, so if there are no other questions and comments for anybody, I don't see it on the chat. I really want to thank Dr. Chao for this great way to celebrate Cancer Day. We all have challenges that we're facing at the local level, at the national, at the international level. I really want to finish with the words that you just said. The reason why we do this don't change, and it will never change. And I think that the other messages, I'm sure that to share your feelings that by doing these things, we get a lot, even more than what we give to people, and that's it's a shared experience that will not only make us keep going, but also will keep us together.
Absolutely.
So thank you very much. And thank you everybody who have attended. Thank you so much. Bye-bye.